we're talking about indirect restorations. We think about margins, tissue management, and isolation. And so in managing this, there's a number of ways you can go. There's not one right way to do anything, right? There's a number of different ways. But margins, based on your materials and your lab technician's skill set, you can place your margins supragingival, equigingival, or subgingival. Now, ideally, if we can keep them equigingival or supragingival, obviously it makes life easy, right? We don't have tissues in the way. We don't have fluids to contend with. Life is simple. Margin placement was critical, we talked about earlier, but now the critical component is isolation. So obviously there's a lot of different ways to isolate, whether it be using an Optrogate from Ivoclar, whether it's rubber dams, whether it's Mylar strips, whether it's Teflon, the saliva ejectors. There's tons of things that you can use. If we can put margins in a good place and we can manage tissues well and put good provisionals on there that mimic the tooth extremely well and are smooth and clean and hygienic, then we get to finally make a choice. And that choice is, how am I going to put things in? What am I going to use? Here's where we start to have failures and problems. It starts with those things that we might have thought were simple, but those set the tone for here. Because I'm going to make a decision on what type of materials I'm going to use. Am I going to use ceramics? Am I going to use zirconia? A lot of different options out there. Our kind of protocol, you can see that at this point, we were at the white where we had tried it in with a water-soluble Trian gel. Having taken that out of the mouth, we now have something slightly different based on the two different types of materials we're dealing with, ceramic versus zirconia. Okay? Now, with the ceramic, since it's already been silanated, I mentioned, you can simply hit that with water, or if you want to go that extra mile and use the ceramic cleaner, that is fine too. Now, in the case of zirconia, this is where it becomes critical, because this is a true contamination that you have to fix. So you're going to have to use a ceramic cleaner. And then after doing so, you then have to add a ceramic primer if you're using traditional resins, so you can get adhesion from the ceramic to your resin. Clean it with a steam cleaner, but if you want to just sit chairside and use your air water syringe, if you've silanated it, that has protected the ceramic, you can simply rinse it off. It's quick and easy, right? So that part is easy. Hence, we have the yes at the top for the ceramic protocol. On the right for zirconia, it's not so simple, okay? You have to add two components to it, okay? You have a phospholipid contamination on the ceramic, the zirconia, from the saliva that cannot be rinsed away no matter how hard you try. Okay? So you have to get specific materials for zirconia to clean the inside using some type of phosphate scavenger system. Zirconia requires you to utilize a ceramic primer. Those primers typically are going to have MDP, the Z prime plus, which allows you to adhere the zirconia to the resin. Okay. Now, as I mentioned, there are other ones out there, whether it's Ultradent, Denmat, Dentsply, GC, Carrari. Many companies have them. And sandblasting, for the most part, should remove, if you've done a thorough job, should remove all the phospholipid contaminant. You probably, if you've done it extremely well, don't even need the zirconia cleanser. But I'd say, you know what? I don't ever want to risk things at this point after, spending all the time and money getting to this point. So I don't have no problem sandblasting it and then putting a little Zirclean in there for some pennies, rinsing it off, and then applying the Z Prime Plus. Okay. So if we've done this to the zirconia and we've already treated our ceramic, we now have to isolate things. So whether it be, rubber dams, isolating and ligating each tooth, whether it's clamps, whether it's isolites, Obtrogates, you decide what it is. I've seen dentists take a very good bonding agent and literally get 2 megapascals of bond strength. And I've seen another dentist get like 90 megapascals. There's a huge variation in technique. And so knowing that technique is the biggest issue, because all of these can bond. Granted, some have higher bond capabilities if one makes them perform. And so here's where problems arise. Number one, don't put the bonding agent out onto the mixing well until you're ready to actually use it. I see some assistants putting it out early, minutes early. And so it's evaporating, it's changing its chemistry. You might have more sensitivity. You might not get as deep of penetration into the tooth. These are all setting you up for problems. Okay. Now, if you are applying a bonding agent to a tooth, this is not where you want to be frugal and try and put one little drop and spread it across all the teeth. You want to actually apply numerous coats on here so that this bonding agent can do its magic of seeping into the tooth, putting multiple coats on. You can see how it's really runny, a lot of material on there. And then when I air thin that to evaporate off the volatile solvents, I have a nice thin kind of sheen to it. There's no pooling. It's at this point, because of its low film thickness and how I applied it, I can have my light cure it. Okay. If you're not confident or comfortable with this part, don't do it because your restoration may not seat. Okay. But it's shown in research that you do get a little better adhesion to the tooth if you have the ability to bond the resin to the tooth before applying the luting resin and your ceramic.